I recently saw my primary care physician. I had never had a colonoscopy. And I don't have a family history, I didn't have any symptoms, and like many doctors, although I was taking care of my blood pressure.
And you're how old now, 42?
So I recently, I've had so many, we were talking about how great healthcare is here. Recently I changed primary care physicians, and so many of my patients have told me how great Shavipur is. And I heard him, speak at Chautauqua. And so I messaged him, and Sherry and I both saw him, my wife Sherry and I. Mm-hmm. And I was embarrassed to tell him I'd never had a colonoscopy, and he said, well, you need to have one. And so I had a Cologuard, which, so they sent it to my house, and I sent it back in, and thinking it would all be fine, but lo and behold, it came back positive. So Shavipur calls me and says, don't worry, I'm sure it's just a polyp. And so first thing I did was I texted.
You did.
Bedford. And so Rudy texted me right back, and he says, I'll have my office call you, which they did immediately. And within a week, I went up the street here after my prep and had a colonoscopy. And before that, I saw you in the hallway up here.
Yep.
He called me down and said, I'd already spoken with you. I told you it was positive, and I was lining up my colectomy.
Yeah, so. we already had you scheduled.
Yeah, you don't need the RVUs though. So so I had the colonoscopy. Everything. I had a tiny polyp, as you guys both know, and everything's fine. But and then we had this educational event here a couple of weeks ago, and Anton spoke, was one of the 4 speakers, and just did a phenomenal job talking about colon cancer and how important it is, and how important screening is, and a lot of the new stuff that's coming out. And then you've got, of course, the Digestive Health program that you guys run, which I think is awesome. So I thought, after my experience, which I thought was phenomenal, and after having worked here now for about 8 years, 8.5 years, and just knowing how great the healthcare is, I think that the people in Los Angeles and around the world just need to know how great it is. And you guys are 2 of the guys that help make that happen. So Rudy, I'll start with you first. I just, I obviously I've known you for several years. I don't know a lot about you. Where are you from originally, and where'd you go to college? Where'd you go to medical school? That sort of thing.
Sure. Well, I was born in the great state of the Bronx, New York.
Yeah.
My family is from Jamaica, and my parents immigrated here back in the 60s, and I was born in the Bronx, New York. Went to a series of boarding schools.
Really?
Yep. And went to college at Fordham University in New York.
Yeah.
From there, proceeded to medical school at Case Western Reserve in Cleveland, Ohio. Had a cousin there who was an OBGYN, wanted to make sure that I realized that New York was not the center of the world.
Yeah.
So she somehow convinced me to go to Cleveland.
Yeah.
So from Cleveland, I went back to New York, to Cornell New York Hospital, where I did my internship and residency, and from there, for whatever reasons, back to Cleveland, to the Cleveland Clinic, where I did my GI fellowship. From there, I spent a year and a half studying advanced endoscopy with a little-known place in Wisconsin, a guy by the name of Joseph Geenan, and went off to practice in San Francisco at California Pacific Medical Center, where I actually became a transplant hepatologist. But I did all of their biliary procedures. One faithful day, I received a call from Gary Gitnick at UCLA asking if I would be interested in coming out to Los Angeles to take up a position at UCLA. A lot of thought and went into it, but I eventually decided that it would be a good move for both myself and my family. So I spent almost 10 years at UCLA as the director of their interventional endoscopy. Had many hats, fellowship director, IRB director, did a variety of things, but eventually I realized that quite frankly, I couldn't afford to stay at UCLA. At that point, I had twins.
Yeah.
Yeah.
Right.
So with the twins and another son, I just said, okay, well, it's time for me to move on. And happily, over the last 20 years now, I've been here at St. John's, and it's been a wonderful experience.
So what do you do primarily now?
With Dr. Bilchick here, Anton, I run the Digestive Health Institute, but director of the GI lab and the senior member, I hate to say, of my of my practice of 6 other physicians.
Yeah.
Yeah.
So tell me a little bit about colon cancer. I know it's a common cancer, and just how common is it? How serious is it? And how is it diagnosed? And
yeah. So unfortunately, colon cancer is the 2nd to 3rd leading cause of cancer death in the United States of America. What we've all seen is a phenomenon of people developing colon cancer at earlier and earlier stages.
Yeah.
So screening of colon cancer comes in a variety of flavors these days. So anything from invasive procedures such as a colonoscopy, which is the gold standard, to what you had, which was a Cologuard study, which is essentially stool in the box looking for DNA that might signal cancer cells. And as you yourself noted, that yours was positive, and we ended up performing a colonoscopy. Fortunately, it was just a polyp. Other methods of screening, these days your primary care physician will do a FIT test, which again requires stool and a chemical reaction in looking at that stool. And also even just something as simple as a guaiac card looking for blood in the stool, which again your primary care physician should be doing almost on a yearly basis. Mm-hmm. So those are essentially the mechanisms.
So there are some people that do a colonoscopy while they're awake. I know some doctors that'll do that. I talked to a patient today.
These are people who want to stay in control. I would never advise a colonoscopy awake, primarily because the endoscopist is typically rushing through the procedure as you're moaning and groaning. And really, the way a colonoscopy should be performed, provided that the prep is adequate, is a 6-minute withdrawal at a minimum, so that you see every square centimeter of the colon.
Yeah.
And the name of the game is to detect adenomatous polyps, which are potentially pre-malignant polyps. Mm-hmm. Mm-hmm. So you want to take the time and effort to look at every square centimeter of the colon during that time. If somebody is actually performing the colonoscopy while they're awake, I can assure you that the endoscopist is not moving as slowly and as diligently as they probably should be.
Yeah. You know, I said earlier that that particular day and having that colonoscopy was one of the best days of the last year I've had. It was so, I woke up so, it was, the staff was excellent. Mm-hmm. I felt great. I remember speaking to you. I mean, I've been impressed with Propofol, because you just immediately you're clear-minded for the most part. Mm-hmm. And it was really, I was ashamed or embarrassed to say that I'd never had one, and it was because it was so easy.
Yeah. Well, that's really the biggest problem. It's the fear of the unknown.
Yeah, exactly right.
And so many people somehow have this negative connotation of what a colonoscopy actually is.
Yeah, right.
And they don't realize it until they've actually gone through it, that it's really not what they thought.
Yeah.
The prep is the worst part of it.
Yes.
And the prep really just entails that you're drinking clear liquids all day and you're taking a laxative. Yes, you're going to the bathroom multiple times. You'll lose a couple pounds while you're at it.
That's a benefit.
Yeah, but that's the worst of it. That really is it. And if your colon is clean and you're an average risk individual, you don't need another one for 10 years.
Yeah. So Anton, I know you're from South Africa originally, and I know that that's where you went to medical school, and then Yale, got your PhD, and then how did you end up in Los Angeles?
Yeah,
and at the Cancer Institute?
Firstly, Tim, I have to say, I think this is the first, discussion I've ever been to that's inspired by a personal experience about colonoscopy. I'm just, just listening to you, I'm just so impressed. It's a first. I don't think I've ever heard of such inspirational words.
I agree.
It's all attributable to Dr. Bedford here.
I'm not sure if the inspiration comes from the propofol or the colonoscopy or a combination thereof.
He's a great
I think
guy.
it's such a, and also I think the fact that here we are on a Friday afternoon sitting together having a chat attests to the closeness among the medical staff and our commitment to what we do and to the hospital and the quality of care that that we aspire to provide, that I believe we do provide.
Absolutely.
Yeah, totally agree, 100%.
Rudy and I have actually worked together in one way or another for over 30 years.
Yeah.
So, we worked together at UCLA, and I was a resident there. Rudy was definitely the go-to guy for everything complex. He still is. But, there were many conversations as a resident, hearing the words, just call Dr. Bedford.
Yeah.
And I have such vivid memories of, this Dr. Bedford always being available and never saying no.
Right.
And this dates back, more than 30 years ago. And that approach, I think we were discussing this earlier on, we sometimes take for granted because we all have the experience of, calling a doctor's office and getting a 1-800 number and then having to be put on hold to call someone else to then find out you can't see the doctor for 6 weeks or 8 weeks.
Right.
I mean, I've tried as a physician to get some of my patients in, unsuccessfully, I might add. We have a completely different approach. I mean, the number of patients that have come to us and said, I've had difficulty swallowing for 8 months and it took me 3 months to get into the doctor, and then it took another 2 weeks for the primary care doctor to call the gastroenterologist. In the meantime, this poor person is losing weight and has esophageal cancer.
Right.
And then comes to visit us, and within an hour, there are multiple phone calls made, and an endoscopy is done, an endoscopic ultrasound, imaging, a medical oncologist is involved, a multi-disciplinary discussion, which is something we take a lot of pride in, because here we are sitting in this world-renowned academic center where a lot of discoveries in the world of cancer started in this building.
Right.
And so we've continued that legacy with all of our patients in terms of multidisciplinary discussion. And then we come up with a plan, and the result from and the response we get from our patients is, why didn't I find you guys, this team before? I cannot believe it took so long. And we often just face, fortunately, a lot of gratitude for just being there and being available.
Yeah, listening to patients.
And just listening.
Yeah, exactly right.
You and I work out of the same clinic.
Yeah.
Awesome. We've had patients today, really complicated patients that have come in from other states that we've operated on together, that are willing to drive from another state to come and get a post-operative or just a follow-up appointment because they have confidence in our team. And that again is just something that I feel is completely unique. I still haven't answered your question.
Maybe tell me more about the Digestive Health Institute and how it was started and what your vision is for it.
I think that one of the problems in healthcare that we all deal with is that healthcare is very fragmented. When you're dealing with complex gastrointestinal problems, it shouldn't take weeks and months to get teams together or to improve communication and to get patients taken care of. And so we recognize the value in better alignment with multidisciplinary teams that are closely intertwined, combined with cutting-edge research, because ultimately I think what we want to be known for is physicians that take great care of our patients, but patients want to know that the physicians that they're seeing are up to date.
Yes.
And that are doing cutting-edge research, and that are doing techniques that that aren't done routinely at other hospitals. This hospital and the physicians here have a reputation for doing that. I vividly remember when Dr. Morton, who has this tremendous legacy in the world of cancer and surgical oncology, came to Santa Monica with close to 200 people from a university nearby, and many people around the country thought, well, what is this academic doctor with a whole team of research scientists going to a community hospital? Can this doctor accomplish the same things? And within a very short period of time, Dr. Morton became the single highest funded investigator from the National Cancer Institute in this building in Santa Monica at this community hospital.
Right.
And I think that has many ways set the precedent for a lot of us in terms of training, and we try and bring that into an aligned digestive health program that involves great clinical care, research, training the physicians of the future, and working closely with our scientists. It's, I think, one of the traps that a lot of physicians fall into is that they work in silos.
Yes.
They work alone, and they don't communicate well. And that's not always in the best interest of the patient. And the Digestive Health Institute provides us a vehicle to provide better care, more accessible care in a community hospital.
Dr. Bedford,
Yes.
so let's say you're doing a colonoscopy and in fact, heaven forbid, or you happen to diagnose colon cancer. It's not a polyp you can just snip off. And so how do you manage that? What's the course? What happens?
Sure. I'll give you an example of just a recent case that both Dr. Bilchick and I have consulted on. 36-year-old.
Really?
Yep. Having bleeding, rectal bleeding for about 4 to 5 months prior. Came in to see me in the office. Immediately, within several days, we got him into a colonoscopy. I found a relatively large mass in the rectal sigmoid area of his colon.
So the lower part
The
of the
lower
colon.
part of the
Yeah,
colon,
sure.
biopsied it. At that point, got on the phone, called Dr. Bilchick, got on the phone, called our oncologist, got on the phone, called our radiology services and put an order in to get CAT scans of his chest, abdomen, and pelvis. And within very short order, literally within a week, everything was compiled in terms of where we were and what was going to need to happen. And within a week from there, he saw Dr. Bilchick and had his surgery. So that's essentially what we do and how we roll. It's just very, very rapid succession of things that are done, and fortunately we can move in this expedited fashion in a way that you cannot find in any other institution.
And how is he doing now?
He got in and out of the hospital within a day and a half.
He had a robotic sigmoid resection and left the hospital in 1.5 days. And I think that
So you use the
we
Da
use
Vinci robot.
we use the Da Vinci robot, and I think that where the Da Vinci robot, thanks to people like you, have been such a force behind robotic surgery, where robotic surgery for an individual like this has such huge advantage is the ability to not touch any intestine at all, so to do everything minimally invasively, do the connections with the assistance of the robot, so that these people are eating immediately, and he probably could have gone home the night of surgery. The stress of this young person, you can only imagine, because the screening age, because we're seeing so many young people with colon cancer, the screening age for colon cancer was reduced in March of 2021 from age 50 to age 45. Well, here we have someone in their 30s, and then next week we're operating on someone in their 20s.
So is there any indication as to why the change is happening?
It's probably multifactorial, and no one, clearly no one has the answer. I mean, there's certain obvious risk factors. obesity, smoking, a sedentary lifestyle, red meat, eating too much processed food. And it may well begin when kids, as kids using vending machines and just eating foods that are processed with artificial sweeteners without paying much attention to fruits and vegetables. But the clock might start ticking at a very young age. There's also evidence that the indiscriminate use of antibiotics may play a role, because our body has millions or trillions of bacteria, and neutralizing these bacteria with unnecessary antibiotics may weaken the immune system and the ability to fight cancer or to prevent cancer. So there are a number of theories. What Dr. Bedford and I see, which is I think quite tough, is that most of these patients don't seem to have these risk factors. They're young, they're thin, they're not smokers, they eat a healthy lifestyle, which again, which just leaves many unanswered questions.
So that begs the question then, so when should someone have their first Cologuard or colonoscopy then?
So if they're average risk, meaning no first degree relatives with colon cancer, then it is the age of 45. But I hate to say it, that by 2050, I think the stats show that maybe upwards of half of all colon cancers will actually be in people below the age of 55, 50.
Wow.
So, I mean, my suspicion is that these screening tests are likely going to even move down as we proceed forward over the years. But right now it is 45. If their colonoscopy is normal, then it's every 10 years afterwards. If you're proceeding with a test like the Cologuard study, then it's every 3 years.
I see.
And that's really where we are today. But it is somewhat frightening.
So you mentioned earlier, Dr. Bedford, that Rudy, that when you in this particular gentleman with the lower colon cancer that you called Dr. Bilchick and the oncologist, the medical oncologist. So when does the medical oncologist get involved, and so with chemotherapy or other newer kinds of systemic treatments?
Yeah, I truly believe that every cancer patient that sees a surgeon should be part of a multidisciplinary discussion.
Yeah, right.
Because cancer care has evolved so much that if a patient that's diagnosed with cancer just sees a surgeon, they may not be getting all the information. I mean, the best results with cancer are based on what we call optimal sequencing. Should we do surgery first? Should we do chemotherapy first to make the tumor smaller and then surgery?
Right.
If so, which chemotherapy should we use? What is the role of radiation?
Yes.
And then there's the whole world of genetic markers and biomarkers. The only way to provide that kind of care is by getting multiple disciplines involved early on without anyone having an ego. I mean, and I think that's a really important point, because there are times that the surgeon and the medical oncologist may disagree on the timing of treatment. And I find that what we do is we all will provide an opinion and then take it to a multidisciplinary discussion. And then at the end of it, with a good, clear conscience, we can tell the patient that we have discussed you.
Yes.
You have options, but our team feels that perhaps you should do some chemotherapy first to make it smaller and surgery later. Whereas if you don't provide that kind of care, you may be doing a disservice to the patient.
Not only is it a valuable service, patients love it, and it gives them a more objective look at really what the best course of action and sequence of treatments are. Rudy, you also mentioned risk factors. So what are the risk factors for colon cancer?
Well, I think that Anton has already outlined them. Smoking, obesity, high intakes of processed foods, red meats, things that are charred, that many of us like to use our grill, and a family history, especially first-degree relative. But before I even go there, let me tell you about something I think is going to be exciting. I don't know if Anton agrees. We're using it now for patients who already have cancer, liquid biopsies.
Yeah.
So there will be a time, I suspect, where you'll go to see your primary care physician and they'll just draw a tube of blood and send it off and see what circulating cells, cancer cells you might have. And that may very well be the screening test, so to speak, for all sorts of cancers. So, I mean, we were part of a study of one of these companies in our office and correlating with our colonoscopy findings. It was actually very interesting to see where this is all leading to.
You know, and with these tests, whether they're blood tests or stool-based tests, getting back to one of your earlier questions, I think as cost comes down, which they have certainly with stool-based tests. I mean, there's also a FIT test, which is a stool-based test, which is, you know, quite a bit less expensive than the Cologuard test, and also quite accurate. But with the cost of these tests coming down, it may well be appropriate to start screening at an even younger age.
Yes, of course.
Because it's not going to be time and cost effective to be doing colonoscopies on every 20-year-old. And quite frankly, there's not data to support that. But as part of a general physical, if it just requires mailing in a stool-based test or a sample of blood, that may reduce the screening age so that we can detect these 30-year-olds and these people in their 20s now. I mean, just again to get back to the statistics, colon cancer is now the leading cause of cancer-related deaths in males under age 45, and it's the second leading cause of cancer-related deaths in women under age 45, second to breast cancer. But the data suggests that in 3 years, it'll be the leading cause of cancer-related deaths in both males and females under age 45, which is just astonishing.
Yes. All right. Well, with that, I want to thank you both.
Our pleasure.
Dr. Bedford and Dr. Bilchick. It's been wonderful to get together and finally get to sit down and have a chat about colon cancer, colonoscopy, and and the institute that you're developing.
I'm glad you had it done. I mean, it's amazing.
But I think there's a really important question that we haven't covered.
Yeah.
That we have to ask of Dr. Wilson.
What
took you so long to get it done?
Yeah.
I'm not asking your age or anything.
So I'll tell you a funny story. You have to turn off the. You can record this. So when I wasn't asleep yet. I was on my side and the anesthesiologist was just beginning to push the propofol. Rudy walks into the room and she says, Dr. Wilson tells me here he's never had a colonoscopy. And Bedford says, well, I've never had a urologist do a rectal exam. And I said, well, here we are. We can kill two birds with one stone.
I did.
What a way to end.